Hello, everyone. Good afternoon. Thank you so much for joining us in the today's session. My name is Varun. I head Hospital Success team at Medlearn. Very warm welcome to each one of you in today's interaction. As you are aware, Medlearn hosts a series of industry expert session to empower and strengthen the healthcare community through knowledge transfer sessions. Today, we are privileged to have one of our experts, one of the renowned faces in infection control and safety across India. One of the faces in infection control policies, compliance, and clinical excellence. Before we give you a brief introduction on Dr. Yamuna's expertise, I would also like to mention that I am one of those privileged, professionals who have got to witness Dr. Yamuna's expertise. I have personally witnessed how Dr. Yamuna uh, prepped up entire Apollo Hospital for the WHO audit, and we successfully won the award for the clinical compliance when excellence. I have seen ma'am designing policies, laid standard from checklist to strengthening the staff members, designing training material to training people across Apollo, training doctors, assisting doctors, ensuring that. There is 100% compliance on the infection control and safety part at Apollo. So, really honored to have ma'am in the discussion today. So, before we get a deeper dive into ma'am's expertise, let us understand a bit about Medlands on what we all do and what are we. I request Subhashri to kindly play the video and post that we can take it ahead. Subhashri.
Hospitals work round the clock to serve patients. Being at the center of the action, hospital physicians and staff must confront every situation and every challenge. They must also keep up with evolving health needs and knowledge through ongoing comprehensive training programs. What they need is a promising solution to ensure a continuous learning journey.
In today's world, technology is transforming life. Be it taxis, food delivery, everything we need is at our fingertips. Education is also going through a transformation, and we are at the forefront in the healthcare industry.
Medlearn is a comprehensive learning, training and skill development platform incubated at Impulsys in India for healthcare professionals to attain the right mix of content, learning and skills that help them throughout their career. The platform offers a wide variety of courses that enable hospitals to meet their employee training and development needs in areas of quality compliance, soft skills and induction. The platform is designed in a way that it enables easy tracking of the real-time status of their learning progress. What's unique about this platform is that it's accessible anytime, anywhere, ensuring quality learning literally at your fingertips. Hospitals can now assign courses and track the competencies of users on specific topics with Medlearn's intelligent assessment tool, which gives them better administrative control. Its superior courseware helps hospitals provide standardized care and bridge skill gaps at every level in the organization. The healthcare professionals will also become more efficient and empowered when their learning journey progresses with ease and at their convenience. Let us unite to improve healthcare in India by spreading knowledge through technology. Medlearn, better prepared for better care.
Thank you so much, Subhashri. We have Mr. Deepak Sharma also with us, who is the CEO and co-founder of Medler. Deepak, I request you to kindly welcome Dr. Yamuna.
Yes, it's my privilege, Dr. Yamuna. I'm so glad you could find the time. I'll say a couple of words. I'm sure most of the people gathered have gathered here to listen to you. So I'll just quickly introduce you and then step back because it's such an important topic. Dr. Emna is a highly accomplished consultant in infection control at Apollo Hospitals, where she's also serves as the head of the department, CSST, and the operating theatre corner. She's got over 15 years of experience as an anesthesiologist and clinical microbiologist. She's a gold medalist from Madras Medical College and board certified infection control by both the Certification Board in Infection Control, CBIC USA, and your Health Department. As a national coordinator for the Antimicrobial Stewardship Program at Apollo, Dr. Evana has been instrumental in securing prestigious awards to Asia Pacific Head Award, CSSC Center of Excellence. This goes on and on. She's also a certified simulation trainer and SHA International Ambassador. She's contributed significantly to medical and paramedical education at the Apollo Simulation Center. In addition to her clinical work, she is certified in leadership and management health from the University of Washington and outbreak management from Johns Hopkins. She is a trustee of the AMR Declaration Trust India and a principal investigator for Apollo Main Hospital with the SHA Research Network. And with such an important topic, I will invite Dr. Yamuna to share her views and welcome again.
Thank you, Mr. Deepak, for that warm welcome. And thank you, Varun, for involving me as the first, involving me as the first speaker in the MedLearn to guide and help people on antimicrobial stewardship. And also thanks for allowing me to select this topic, which is very close to my heart and which is the day in and day out practices, what we do at Apollo. So allow me to share my screen. So my today's topic is on advancements in antimicrobial stewardship, the best practices and the emerging strategies. As we all know, antimicrobial resistance is not only present in developing countries, but it is also there in the developed countries, where we see that every year 14,000 patients die because of Clostridioides difficile infection in US. The reason behind antimicrobial resistance. 23,000 patients die each year as a result of antimicrobial resistant infections in the US, and around 25,000 patients die every year due to antimicrobial resistance in Europe. And in India, one child dies every 9 minutes because of an infection caused by antimicrobial resistance. When we look into our Indian perspective, it says that 6 to 7% is the annual rate at which the antibiotic utilization in India has gone up, and 47% of patients, they insist the doctors to write antibiotics. And 53% of the patients self-medicate themselves, and 1 in 4 of them never finish the course of antibiotic. And even 70% of doctors prescribe antibiotics for common cold, which is caused by viral disease. 50% of pharmacists or the chemist, they sell antibiotics without prescription, which we call it as on-counter sale antibiotics. So this is how the Indian perspective also says that the antimicrobial resistance related direct attributable cost to death is somewhere around 30% among all the deaths which is associated with antimicrobial resistance. And that is the third commonest reason due to which people are dying following cardiovascular disease and chronic respiratory disease. Why do people give unnecessary antibiotic therapy? The reason why, because certain mild infections like cystitis or mild infections like URI, they may not require antibiotic, but if at all they require, the course is never more than 3 days. But people tend to increase the duration of therapy, and that also leads to antimicrobial resistance and unnecessary antimicrobial. Non-infectious and non-bacterial syndrome, like I already mentioned, URI, which is most commonly viral infection, unnecessary antibiotic. Some people tend to treat even infections, which is tend to treat colonization and contamination, which they think that it's probably an infection, and keep treating the patients for longer duration of time. And redundant, patients are started on antibiotic, but people forget to stop them, and it just remains and goes on and on for them. But what is basically an antimicrobial stewardship? It is nothing but a coordinated, designed approach to improve and measure the appropriate use of antimicrobial agents by promoting the selection of the optimal antimicrobial drug regimen, including dosing, duration of therapy, and route of administration. Why is it important? Because to improve the patient outcome, to reduce the adverse reaction and unintended consequences, and ensure cost-effective therapy. Because the more antibiotic, the more cost for the patients, and also a very detrimental outcome. Stewardship was important. Why? Because of increased resistance of AMR and also dry antibiotic pipeline. Of late, we don't see new antibiotics coming in. We often see antibiotics which are not new, but it's a combination of the existing antibiotic into various combinations being done and trying it out so that we can preserve the other high-end antibiotics. Why antibiotics are not like most of the drugs. When we start a drug or a treatment for a patient, it is only linked or directed towards the patient. The clinical effectiveness and the toxicity is directly related to the patient, and the drug effect stops there. Whereas in an antibiotic, if we give one drug to the patient, he ends up or she ends up having a clinical effect, microbicidal effect, and toxicity. This does not stay only with the patient, but it would also lead to eradication of that bug or the bacteria, and increased resistance of the bug because of such an inappropriate antibiotic, and thereby it would lead to treatment failure, transit resistance, colonize the patient, and from there it can move to the environment, and thereby it can spread to other patients. So that's how I say that antibiotic given to one person can lead to a collateral damage not only to the same person but also to the community. So this is the overall picture as published by WHO, which tells us about the increasing rate of antimicrobial resistance as far as gram-positive or gram-negative bacteria goes. When we see our country laid down here, either for a gene called as KPC gene or a ESBL gene or NDM, India seems to be the highest and having the highest rate of antimicrobial resistance among gram-negative bacteria, which is around 80% for ESBL, 70 to 80%, and for KPC, it is somewhere around 50 to 60%. In 2010, this is what the world's largest consumer of antibiotic for human health shows, that too in India. Among the other antibiotics, the commonest one which is used predominantly are the cephalosporins. And where did we start? With an example. We started this way back in 1989, where the fallacies in antibiotic therapy, that point of time was that bigger the best or longer the drug, that's the best. So that point of time, the trademark statement or the guidelines were broader is the best, more disease, give more drugs. Bigger the disease, bigger the drugs, and antibiotics are non-toxic. So this was the fallacies which was laid down in the year 1989. And we are still sometimes hostage to the history. As said by one of the senior doctors to their fellowship during their fellowship period, how they were being taught that, Emily, just treat the patient until they are better and stop worrying so much. This is what the treatment used to be in olden days, where they want to hit hard and treat whatever it is there available and whatever duration, just give antibiotic to the patient. But why do the prescribers do this? Why do the prescribers are forced to give antibiotic? What are the challenges they face? Many times people do not have microbiology lab available in the nearby area. So there is a diagnostic uncertainty, unclear differentiation of purulent versus non-purulent. Fear of being wrong. What if I go wrong? What if I lose a patient? Desire to cover everything. Why should I leave this bacteria? Why should I give only this antibiotic? Let me cover everything under the sun which is available. Additive adverse risk for benefit. Patient risk profile, lack of time for them, because if a patient is crashing, coming to an emergency where there is limited time available for them to treat, it happens. Fear of litigation. Will I be questioned in the court of law for not giving this treatment? Will I be questioned by the customer or the patient for not giving this antibiotic for this particular treatment? Will I face any litigation issue? A knee-jerk reflex or a practice pattern or peer practice. This is how I was trained, or I have been trained by my senior. That's why I keep continuing the same. But the goals of antimicrobial stewardship is, of course, patient outcome, patient safety, reduce the antimicrobial resistance, and reduce healthcare cost. The National Action Plan or the Antimicrobial Resistance Strategy prioritizes these 6 aspects to which we need to focus on. First is about awareness and understanding. So that's what we are now sharing and doing, education and training. As much as possible, educate the people, create awareness among the people that larger is not the best, bigger is not the best, and broader and treating for a longer duration is never the best to reduce antimicrobial resistance. Next is about knowledge and evidence, where by doing a surveillance culture or by having an appropriate laboratory support, we can do it. Antimicrobial stewardship always goes in hand with infection control protocol. Infection prevention and control in the hospital would in turn help us to deal with stewardship practices in a much better way. Optimize the use by regulations, stewardship practices at the hospital level, and not only in the human health, but also at the agriculture level. Innovate and do more research and diagnostics, innovation of new medicine, innovation of new diagnostics, and thereby financing all this would help us to come down on these stewardship failures or in stewardship challenges. Leadership plays a very important role, not only the leadership at the regional or at the local level, but we need to have a leadership as a team at the internationally, nationally, and also at the state level. So how the healthcare and administrative level practices can be of great help whenever we are doing stewardship practices. So as I already mentioned, 3 of the practices always goes hand in hand, which we call it as AID. That is antimicrobial stewardship, diagnostic stewardship, and then comes the infection control stewardship. When you have all these disciplinary team within you and within your hospital, then stewardship practices would be at par, and it's very easy to manage it at the healthcare level. Who needs to be on your team? So which are all the people who has to be part of the stewardship practices? If I take the content expert, it could be an infectious disease doctor if they are available in your hospital. If they are not available, this could be any general physician or a clinician who has an expert knowledge in the utilization or usage of antimicrobial agents. A microbiology lab, infection prevention and control group, or a hospital infection control committee person, or the infection control officer should be part of it. Antimicrobial stewardship expert who can be a very good steward, who practices good stewardship practice within the hospital, can be a part of it. So who needs to be on your team? So I mentioned the content aspect should be part of it, end users, and the strategy specific. In strategy specific, you need to have an IT team if you have a good hospital information system or a laboratory information system. And the way forward where we are going is the electronic health record. If that's a part of it, then it would help us to keep things in place. You also need to have a top-down and a bottom-up approach by which you will be having a day-to-day regulation of the stewardship practices, which would be discussed on a regular basis with your leadership team. The CDC also gives a wonderful document on core elements of antimicrobial stewardship. Do read or go through this a very beautiful document which talks about the 7 important core elements of antimicrobial stewardship, including leadership, commitment, accountability, drug expertise, action, tracking, reporting, and education in a very structured way, which helps us to identify how in what way we need to begin the stewardship practice. It also has a very good checklist to determine us and also to ensure that where can we rate ourselves in the current practice and where we are planning to head towards. This is also a very nice stewardship guidelines, which talks about 2 important aspects that if I want to start stewardship, how should I do? If I belong to a private practice setup, if I belong to a public health sector, what should I do? So predominantly, there are 2 front-end strategies which can be helpful. One is prospective audit, intervention, and feedback. And the other one is also called as formulary restriction. So prospective audit and intervention and feedback is an important front-end strategies which can be practiced in a private setup, where we respect the autonomy of individual consultants or the antibiotic prescribers to initiate the antibiotics upfront, but writing a justification why they have started antibiotic, and later after 48 hours, giving them a feedback and telling whether it is right or wrong based on the culture report. The next level of front-end strategies is formulary restriction, which is very commonly adapted in public hospitals and in academic institutes, where it's very easy to control the other person. It can be used in private hospitals for new upcoming antibiotics and not for everything. So this is what we call it as a collaborative stewardship or a handshake stewardship practice, by which in prospective audit and feedback, we allow the consultants to begin the antibiotic, but on a later run, we help them to or handhold them by not allowing them to continue the unnecessary antibiotic. And that's what we call it as a handshake stewardship. How should I begin the steps of stewardship practice? It's just an overview of steps. Perform a situation analysis. Situation analysis can also be done by a point prevalence survey. It's like a dipstick test, which you can do at place wherever you are practicing to understand what is happening in the hospital. We need not sit and reanalyze the entire 6 months data or 12 months data, but you can do a dipstick analysis by doing a point prevalence study is what actually happening in my hospital on a daily basis. Second step, obtain approval for stewardship activities, create a team, set goals for the team, roles and responsibilities. What should we do? Step 5, select interventions. What am I going to do? Am I going to bring under one umbrella all kinds of antibiotics, or I'm going to concentrate on one major antibiotic, which is a challenge in my hospital? Step 6, select key performance indicators. What am I going to monitor? How am I going to make sure that I have achieved my goal towards the end? So set your key performance indicators, and also you can have a very strict goal or an overall goal by which you see a reduction. Implement, educate, and train, which is an ongoing process which has to be done on a regular basis. Monitor and report the progress. So each stewardship needs to determine which components will work for them in their hospital. It's not that whatever I am practicing in a private setup in Apollo Hospital is feasible to every one of us or every one of you to do in your own hospital, but we need to determine the components which is feasible for me and in my hospital to perform. Always remember the 3 C's of stewardship communication, which is communication, context, and collaboration. Communication means that in what format will you communicate the stewardship practice? Will you communicate to the other person in a written format, in an oral format, or through a mail format? That's a level of communication which you need to determine. And whom will you communicate? Is it to the junior doctor, to the coordinator, or directly to the consultant who writes the antibiotic? Context. What are the circumstances surrounding the person you will be communicating with is very, very important. And how will you into account their challenges, perspectives, and professional culture when you convey your stewardship message? And what questions needs to be asked to better determine motivation and context of the prescriber? The reason why, because each one of us come from a different background. Each one of us are trained in a different way in our setup. Each one of us had a mentor who was totally different. So we need to understand all these situations or what kind of patient, the workload they are dealing with before even we approach a person to talk on the stewardship practice. So understand the context behind it, and also try always to collaborate with the people. So how will you approach the stewardship interaction with relationship building in mind? And how can I build in the trust with that opposite person with whom I am planning to create the stewardship practice? Because it's not something very easy to stop someone from prescribing an antibiotic within a hospital setup, because every one of us as a doctor think that it is our right to write the antibiotic. How can someone stop us? So in order to do that, we need to have all 3 C's in our life, like communicate, understand the context, and collaborate with the other person to make stewardship practice in place. So this is a very formal high-end antibiotic stewardship form, what we practice at Apollo Main Hospital, where we make the consultants to write why they are starting antibiotic, what is the justification, did they send an culture before starting the antibiotic, and what is the syndrome which they are thinking about. So back end of the form also has an explanation for the infection control team whether this antibiotic is justified or not. If it's not justified, then it gets critically reviewed by the ID consultant, and then the response is shared with the clinician. If the clinician agrees to the practices, fine, very well and good. Otherwise, there is one step ahead where the administrative team also steps in. So this is a very nice study to say that whether real-timely audit and feedback does make any intervention. If I make only one component in my stewardship practice, that I will observe whatever stewardship practice is happening, and then on a regular point of time, I'll be giving a feedback to the clinician. So does this help? This is one study published in BMJ, which says that there is a significant 5% relative reduction in overall antibiotic prescribing date only by audit and feedback, 11% relative reduction in unnecessary antibiotic prescription, 15% relative reduction in antibiotic duration more than 7 days, and 6% relative reduction on broad spectrum antibiotic prescribing. So this is not a very huge number to begin with, 6%, 5%. It may sound very less, but in a stewardship, over a long run, this would make a maximum or a major change as a cultural change which can happen within the organization. So how can we address stewardship practice through the microbiology laboratory level? So know your local data. This is very, very important. Whenever we are dealing with people or public to understand what is their culture, which I already told at the beginning, we need to know local data. What I mean is their antibiogram. So how do we, what kind of resistance pattern do we have? What kind of susceptibility we have? What are the top 5 prevalent organisms which I have in the hospital, and alert the clinical team whenever there is a culture growth from the critical care area. The microbiology lab can also support in reporting early to the clinician, for example, by using rapid molecular method. BSID panels have come into place, MALDI-TOF is in place, then automated kind of blood culture reporting or readers are available, by which the turnaround time of getting to know about the bugs available is very much easier. Within 48 hours, the reports can come in. With the BSID from the culture positive blood bottles, the turnover period is only 2 hours. You will not only come to know the ID of the bug, but you will also identify the resistance pattern. This is one of the study which we published recently from our center, which talks about the utility of these PCR panel, multiplex PCR panel for identification of the bug. Not only that, in your hospital information system or the LIS system, you can have the easiest way of tracking when the sample was collected, the specimen collection, who collected the sample, what was the diagnosis, what was the time at which the culture was collected, the time at which the sample reached the microbiology lab. By looking into the turnaround time or the turnover time, it will be very easy for us to determine whether it was an appropriate sample which reached the lab on appropriate time period, and when was the report came on the LIS system so that I can retrieve it. So by tracking these turnover time from the lab to the clinical area, it makes things even more easier to set stewardship practices, and the duration within which the de-escalation of antibiotic happens at the patient's bedside also happens at a faster rate. Garbage in and garbage out. This is a very important example. The reason why, because if the culture sent from the clinical team is not appropriate, then the culture processed by the microbiology lab is also not very good. For example, if there was a request only mentioned as urine culture sensitivity, and the lab sees that there are more than 3 colony forming units, unnecessary susceptibility would be reported, and it leads to unnecessary treatment for the patient. Whereas the underlying history was, it was a sample sent from a patient who had a prolonged catheterized present in place, Foley catheter in place. The second example, if something is written as fluid, whereas the reality it was an endotracheal aspirate, and unnecessary reporting from the lab as candida present in this fluid has been reported, and the patient was treated unnecessarily with antifungal agents. One more fluid example is an OR specimen from a suprapubic space, which was nothing but a commensal or contaminant of the urogenital system, which need not be treated. If you just mention as pus in the antimicrobial, in the specimen collection report, and miss to write from where the pus sample was sent, then the important antimicrobial susceptibility pattern for the brain abscess would be missed by the laboratory. So if you send in good culture, if you send in good specimen, if you give appropriate documentation on the appropriate specimen, then definitely you will get a proper culture report from microbiology laboratory. The lab can also choose to do cascading, selective reporting and cascading, and also by adding wonderful remarks behind or below every report in order to validate the report of the clinical specimen. If a particular antibiotic or if a particular specimen or a bacteria is sensitive to more than 10 antibiotics, the lab can choose to report only the most important top 5 antibiotic and hide all other unnecessary or high-end antibiotic if it's very much sensitive to the first line and second line of antibiotic. That is what is called as selective reporting and antimicrobial susceptibility testing cascading. The relationship between diagnostic and antimicrobial stewardship goes this way. Symptoms, clinical suspicion to the test, patient gets evaluated, patient gets tested, ordering, collection, and processing of reporting, initial diagnosis and empiric therapy, prescribing guidance can start at this level if you have appropriate diagnostic stewardship in place and an antimicrobial stewardship. So this hell lot of time spent or wasted on unnecessary antibiotic can be prevented. The test result can be interpreted, and once the test result is interpreted, a decision can be taken easily at the antimicrobial stewardship team to refine the diagnosis and also refine the therapy. And thereby, we can reduce unnecessary antibiotic exposure, finalize the diagnosis, and finalize the treatment regimen. How can we make changes at the process level? As an antibiotic policy, these are the process level measures which can be done at the administrative level, like policies that support optimal antibiotic use, broad interventions to improve antibiotic use, particularly on high-end antibiotic, guidelines or creation of clinical pathway by which we can prioritize the pathways appropriately, like creating a sepsis pathway by which you don't miss out the important steps that has to be followed during stewardship practices. Prioritize the efforts like specific conditions, particular units or prescriber group. For example, if you have a high antibiotic usage in particular an intensive care unit of your hospital, you can keep stewardship practice or begin your stewardship practice in that unit. If you have a group of surgeons who give a lot of antibiotics unnecessarily to the patients, you can have a stewardship practice prioritized to that particular prescriber group also. And you can also focus the prioritization to a specific kind of antibiotic if its utilization is very high. For example, colistin utilization is very high in my hospital. So I will choose colistin as one of the most important high-end antibiotic, and I will focus stewardship practices towards it. You can also create policies based on infection and syndrome. The most easiest and the easiest one to create, to follow, and also put things in place is the surgical antibiotic prophylaxis can be created on the basis and type of surgery. The four important moments which every one of us should think or take before deciding on any antibiotic is that, does my patient have an infection that requires antibiotic? Have I ordered appropriate cultures before starting antibiotic? What empiric therapy should I start? A day or more has passed. Can I stop antibiotic? Is my patient improving? Or can I narrow down the antibiotic from the broad spectrum? Or can I switch from IV to oral therapy if the patient is doing very well and taking things orally? What duration of antibiotic therapy is actually needed for my patient during this diagnosis? So always think about these four moments of antibiotic decision making. You can also create such guidelines or clinical pathway that if I have a VAP, these are my top 4 or 5 microorganisms. These are the antibiotics which I would prescribe. If I have UTI caught within my hospital, these are my recommended antibiotic. These kinds of guideline stewardship practice is very much feasible as an empiric choice of antibiotic. This is our sepsis pathway, which we had created in emergency department because that is the place where patients land up having sepsis all the time and can get missed out because of a mixing of many other cases which mimic like sepsis and can be missed out as not treating as sepsis. You can improvise on the steps involved like choice of antibiotics, sending cultures appropriately, doing an ABG, and also monitoring the patients hemodynamically, and also giving them an appropriate maintenance fluids. You can also create a wonderful antibiotic nurse flow. The clinical pharmacist plays a very important role as far as US or other European country goes. But as far as our country goes, if we do not have a trained clinical pharmacist, our nurses are not lesser than them. We can very well train them. And the nurse can be used as a nudge to the physician or to the surgeon whenever they are choosing an inappropriate antibiotic, and thereby sending reminders and feedback to these people so that we can come down on unnecessary antibiotic utilization. Look into the 4 Ds of antimicrobial stewardship. Am I giving a right drug, right dose, de-escalation, or at the right duration. These 4 parameters can also be chosen as your process indicators to see how many people are giving drug compliance, how many people are giving the right dose, how many doctors are de-escalating the antibiotics, and how many of them are giving duration. These all measurement of parameters can help you to improve the process indicators also. So this is an example of how we can improve process measures, as I already mentioned, based on indication, prescriber, reviewing, and stop order. And also for surgical prophylaxis, you can look into indication, prescribing, and when they are stopping it. So as we say, the newer guideline says shorter is the best or the better. Default treatment duration for uncomplicated infections need not exceed more than 7 days. So the new norm in stewardship practices, shorter is better for most of the community acquired infection. So take an opportunity always to look into the key performance indicators, either related to process indicators or an outcome indicators. Create an improvement trend or show it or put it in a very nice trend graph and share it with your clinical team to understand where do we stand and how are we progressing. Are we even sustenance in the process, or have we dipped down in our process over a period of time? So this keeps it at par with other organizations. This keeps it at par within our organization and as a discussion mode. You can also keep or place these prophylaxis or the empiric choice guidelines or antibiotic guidelines can be placed in different places wherever clinicians sit, in their waiting room, maybe the clinician's lounge, maybe in their area where they eat food, where they discuss, or in their outpatient department. It's up to you where you want to train and educate your clinicians. These kinds of posters can be kept on. So choice of prophylaxis, as I already mentioned, you can depict in the form of trend analysis by looking into whether patients are getting antibiotic within 1 hour of incision, whether the choice of surgical prophylaxis was appropriate. Not only that, government has also come up with newer and emerging practices as given by Schedule H1 or the drug warning, which says that anything which is labeled with this box called as H1 notification, you need to identify the patient, you need to contact the details of the prescriber, and you need to name and dispense the quantity of drug in their registry. This is what is mandatory for all the pharmacists wherever they are dispensing these medicines from their area. So these antibiotics can be sold only with a prescription from a registered medical practitioner. Now, recently, they have also launched by the Indian Ministry of Health and Family Welfare in 2016, which shows us a red vertical line on the antibiotic packing, which indicates that, again, these medicines should only be dispensed on prescription. Not only a red box with H1 schedule, but it also has a vertical line, and these red line antibiotics cannot be sold over the counter without an appropriate prescription. Previously, they just used to maintain a register, but now they cannot sell these antibiotics if something has a red vertical line on the box. So this is also a new regulatory norms which was shared by the Ministry of Health and Family Welfare, that the hospital needs to have a pre-authorization committee, and they need to implement an audit committee on the antimicrobial usage in the institution. But this was very much particular to the public organizations like a medical college or hospitals or public health hospitals. This practice also has to, the private hospitals also has to adapt this practice to look their feasibility of doing stewardship practice. So my final thought on antimicrobial stewardship is that rapid increase of new diagnostic requires a proactive and methodological approach to maximize the benefit and limit inappropriate use. Antimicrobial stewardship and diagnostic stewardship should go hand in hand. They need to share the common goals and practice in order to collaborate particularly and with all other disciplines existing in the organization. Improved diagnosis can lead to a better decision making, and it would help to target more and good antimicrobial therapy, and thereby would improve the patient outcomes. Are there any questions?
Wonderful session. Ma'am, thank you so much for such comprehensive insights. Let's open the forum for the Q&A. We can quickly take few questions if there are any. Uh, I'll just quickly check if there are any questions. Members who have joined can start posting their questions. Ma'am, the first question is what are the common challenges faced in implementing the stewardship program and how someone can overcome the common challenges in the routine?
Yeah, the common challenges is, as I mentioned, in three C's, that why a stewardship team has to intervene in my antimicrobial practice. Why is that I am being questioned every time? Why is that I am not given the leverage to treat my patient? That's the first and foremost challenge when we talk with the clinician. To address that issue, we need to have a strong leadership support. Leadership support, I mean, is the dean, the director of medical service need to support within the hospital, empower the stewardship team and tell them that you are placed here, you can go and ask questions to the clinician, and thereby we can mitigate their measures and mitigate their unnecessary antibiotic use. I think that that's a commonest challenge what we face. The second important challenge is about how do we collect data? How do I even come to know that there is an high-end antibiotic usage happening in my hospital? So that these are the two important challenges. How will I know and how will I confront the person who is giving this antibiotic? So the first challenge I already mentioned, you need to have a strong leadership support to overcome it. How would I come to know? Definitely, if nowadays in private hospitals or even in public sector, the antibiotics which is getting dispensed from the pharmacy before the time it reaches to the patient, we can get the backend data from the pharmacy team also, so that we know that which are all the areas and which are the patients who are receiving these antibiotic. By looking back end, we can definitely go and track those antibiotic. If that is not possible, you can choose one areas in the hospital, as I mentioned. You do a point prevalence study, see in which unit of hospital the antibiotic utilization is high. So you keep one person who does a daily audit for that particular area, maybe it's a 20 bed or 30 bed, and thereby you can overcome by knowing the data what actually happens there.
Okay, ma'am, I guess with that you have already responded to another question, that how data analysis plays an important role in the success of antimicrobial stewardship. Ma'am, another question is how can a hospital measure the impact of the stewardship efforts?
In my series of the slides which I shared, I mentioned about process indicators and outcome indicators. Outcome indicators are very difficult to monitor in the beginning. Outcome indicators, what I mean is, did you see a reduction in antimicrobial resistance pattern? Did you see a reduction in mortality directly due to antimicrobial? These are all very difficult outcome measures. But as a process indicators, you can see, for example, I want to measure how many doctors before starting antibiotics send cultures for the patient. That's my process indicator. So I can collect how many antibiotics were started in the denominator. In the numerator, I can count the number of cultures sent. So for this month, my culture compliance was 20%. By the end of third month, if I'm able to improve by 10% also, that's my improvement in my key performance indicator. That could be one of your process indicator. The second process indicator could be that de-escalation rate. Okay, my doctors start on high-end antibiotic like meropenem, but within 2 days or 3 days, they come down to another narrow spectrum antibiotic. So that also can be chosen as your process indicator. Third process indicator, many doctors start two antibiotics or a combination of antibiotic, but within 24 hours, they make as uni antibiotic or one antibiotic is given. So that's also a kind of de-escalation which can be used as a process indicator. So this is the impact, the short impact or the short-term impact by which you can easily collect data within a period of 3 months or to 4 months.
I'm taking one last question, and I guess this question we keep on getting from our existing hospitals with Medlan also. When they are designing the calendar for every month, what are the must-have trainings you would like to suggest that it should be a part of the monthly training planner of every employee, specifically the clinical employees of the hospital?
Yeah, strategies to be used to educate healthcare staff about antimicrobial resistance, that whenever the newcomer comes in, we need to orient them about the hospital culture, that this is what we do here. This is what is practiced here. Because many times, even on ground level, when we practice, the moment we question a doctor, they will say that this is what I practice. Why are you questioning me? So the moment they enter into the organization itself, if we could give them a brief structure that there is a stewardship practice, there is a stewardship nurse who will be questioning you. There is a antimicrobial stewardship consultant who has to be consulted if you are giving such and such list of antibiotics. So it's a mandatory requirement of this hospital as a culture, as a policy. If the newcomer is streamlined on the process, that's the first step at least they would recognize. Second important thing is that we can also tell them the different types of diagnostics which is available in this hospital. We can also mention them about the turnover period, that if you send a blood culture, within a period of 48 hours, you will be able to know the diagnostic. So if the people or the clinicians are confident about the clinical outcome and also the diagnostics for their patients, then it will be easy for them to monitor and cut down on the usage of antibiotic. So these small bits of information has to be fed to the clinician on a regular basis. Not only that, the hospital should circulate the antibiotic policy, antibiogram, which I mentioned in my know your local data. So probably a clinician would be a practitioner in US. He would be practicing in UK, and suddenly he comes to India and starts his new practice. So that practice change would take time, right? So they need to understand our local antibiotic data. What are the common bugs which we have in our hospital for which you need to treat? So that policies can be shared with these newcomers when they step up into the organization. And the last strategy is feedback, feedback, and feedback. Education is not possible on a daily basis, but you can interact with such people on a regular basis by giving them appropriate feedback mechanisms. And that's what I say that the important strategies by which we can educate the healthcare staff within the hospital. Or you can try
Ma'am,
your innovative ways. I mean, we have tried multiple innovative ways. We had created small booklet for the clinicians. We put stalls for the clinicians on the floor. We conduct debate for them. We conduct quiz competition. So these are the other modalities by which we can make things more acceptable way, and in a very jolly well mood, we can educate them also, rather than having a didactic lecture all the time.
ma'am, this could be controversial, but do you think before the antimicrobial resistance, there is a people resistance that any committee has to overcome, specifically the clinicians' resistance,
Yeah. So that's what I mentioned.
the
Clinician
leadership support?
resistance would be there, but you need to have a strong leadership. The moment we talk to the clinician, the next phone call would always go to the leadership team that such and such person is disturbing me or stopping me from giving antibiotic. If the leader says that no, they are talking to you on behalf of this organization culture, you please listen to them. Once they give that idea to the clinician, they will stop complaining about it and they will start accepting it as a practice, because we have faced it on and off. Whenever we get a newcomer, they always we find it, we struggle with them in the beginning, that they don't adapt our practice, they feel dejected, they are upset by this behavior. So that's the reason why I mentioned about the 3 C's. No, collaborate. You know their condition from where they have come, and then you come in. It's not that directly we also don't go and tell them and teach them that no, you are wrong, don't give it like this. So we also talk with them that, sir, are you aware that there is a stewardship practice happening in this hospital? Did anybody brief you about it? Where are you coming from? What is your, we begin our talk or communication that way. So when we talk like that, the clinician also feels that the other opposite person is trying to help them out. We are not someone to go and restrict them, but we are someone who like to collaborate and help them out in a better patient outcome. If we give that culture of safety to them, I think the clinicians would definitely start listening to you.
Great. Thank you so much, ma'am. And with that, time for us to wrap up this particular session. Ma'am, on behalf of entire Medland team and all the participants who joined today, thank you so much for agreeing to do this for us. It was really insightful. This is for everyone that those who wants to revisit or revise or retain any of the aspects that has already been discussed by Dr. Yamuna, we would be uploading the recording of this particular session on our LinkedIn page. You can check our LinkedIn page. Also, you can check our website for the upcoming expert programs that we are planning. So stay tuned and thank you so much for attending today's session. We wish you all a very happy learning experience and a great weekend ahead. Thank you so much. Thank you, ma'am.
Thank you.